thank you for the kind words. And I haven't been here for a while, but I've been here a lot of times. And what's always so nice is seeing dear, dear friends and colleagues from way back at the beginning, and also meeting new people. And it's just a pleasure to be here. I remember early on in our center's life talking with Anka as we were starting to develop a center plan, and this has always been a beacon for me and for us in the Midwest. Thank you for letting me come. Today I'm going to talk about something called It's Not Just the Individual, and how we can go about marshaling social supports to improve HIV prevention and care outcomes. Somebody told me I always begin by saying what the objective is of the presentation, so these are the objectives. Today I'd like to highlight how people's social environments, including social norms, social supports, and social network characteristics, influence their risk and their care-related behavior. Suggest that the role of social influence is still neglected in the HIV prevention field, and that this neglect may be increasing with the advent of biomedical HIV as a primary prevention strategy. I'd like to provide a couple of examples of how HIV care linkage, retention, and adherence will achieve greater public health impact through social and community interventions, and illustrate how interventions to address some of these problems can be undertaken with examples drawn from our research in the United States and abroad. Okay, that's all right. I'm fine. I am fine. I'm okay.
You can see this one?
Maybe. Yeah, maybe I'll. It's okay. Okay. Oh, this is better. Thank you.
That's good.
Thank you.
Just do that.
That's good enough.
Yeah.
You know, can you hear me okay if I do it, if I talk like this? Yeah. Okay. Since the earliest days of AIDS, since the very, very beginning, research has unequivocally shown that social norms and social supports influence risk reduction and care-related behavior. I don't know if anybody remember the name of Leon McCusick? Yeah. So he was doing research in San Francisco in 1983 or 4, somewhere like that. And he published some of the very first studies that showed that social norms influence condom use among MSM way in an era before. There have been hundreds and hundreds of studies, maybe thousands, that show that normative perceptions are strong determinants of high-risk sexual behavior, condom use, drug injection practices. If an action is believed to be normative and supported by important social reference around you, it's much more likely to occur. Seems logical. Now, there are different kinds of social models that are influential in different life areas, but friends and acquaintances, especially those who are seen as like oneself and whose opinions are valued, are especially salient in many HIV risk-related behaviors. Who are those models? Well, if you're a gay man, there are probably other gay men. If you're a woman, there may be other women. If you're a teenager, there are probably other teenagers. If you're HIV positive, probably other people you know are positive. So those are important models. So in this way, social network, your immediate circle of friends and others with whom they are interconnected, influence risk and also health-related behavior, because networks are social environments that help to explain the behavior of network members, but they also constitute vehicles for intervention. And that's what I'm going to be focusing on in my examples today. Okay, this talk, we're going to go from Russia to Milwaukee to Russia to Milwaukee. Sounds like one of my travel notes. But tell you why, we actually started a lot of this stuff in Russia because social influences are important everywhere. They're important in New York. They're important in every place. But they're really important in a place where you can't trust other people. Where you can't. Social networks play an especially important role in post-Soviet region countries. In Eastern Europe, people have relied on their personally known contacts for trusted advice, information, help, and support forever. During the 70-year Soviet era, government pronouncements were either viewed as irrelevant to your circumstances or maybe as propaganda, and people back in that era would talk with others at the kitchen table kind of conversations. They'd meet and be able to talk and get right information from people that they knew and that they trusted. And even after the communist Soviet Union ended, governments continue to be viewed with skepticism, especially in marginalized communities, and especially in Russia, and I would say for pretty good reason. About 15 years ago, my colleague Yuri Amirhanian came to CAIR from St. Petersburg as a Fogarty Fellow. We weren't going to let him go home. He joined our faculty and developed a model for using social networks as a vehicle for both reaching community populations and also delivering HIV prevention interventions. And a lot of what I'm going to talk about here is rooted in some of his models and work. We published a study just a couple months ago. It came out in AIDS, Effects of a Social Network HIV-STD Prevention Intervention for MSM in Russia and Hungary, a randomized trial. And I'm going to talk a little bit about that study. In this trial, we wanted to determine whether a social network intervention could reach high-risk MSM hidden in the community, could reduce their sexual risk behavior, and could reduce incident STDs and HIV infection. Russia, as you probably are aware, is a pretty homophobic place and getting worse. There are a lot of government policies that are increasingly, the community, I used to live in Mississippi, and gay communities were under siege. Same thing in Russia right now. And also Budapest, Hungary, which is known as a sort of a liberal place, or it was years ago, but it's also become very conservative and awfully homophobic. And that's where we did this work. So we're working in these environments that are not very officially supportive. The trial that we did recruited 18, we call them seeds. Other people call them indexes. And we found MSM in community venues, including bars, private parties, sex-oriented venues, cruising areas, some place. And we reached out to people. We couldn't come in from Milwaukee and say, here we are. We obviously worked through trusted local people in order to do this. And as part of our initial conversation with each seed, we asked him if he could identify to us, only by his first name, only first names, we're not trying to, his friends who were also MSM. And so we have the seed and this ring of people surrounding the seed. And we invited them into the study too. When they came in, everybody in the first ring was also asked the same thing. Can you name the first names of your friends and invite them in? And we repeated this three times. So we ended up 3 rings out from that initial seed until we got these sociocentric kind of networks. The 18 networks included 626 people, around 35 people per network. Let me show you what one of them looks like. Cisco. All right, that's our seed. And the seed, those are the seed's friends. And the arrows, by the way, indicate who names who. All right, so in many cases, they name one another. Then this is the first ring, and they name the second ring, and the second ring people name the third ring people, and that's how far this whole thing went. It's not really RDS. It's not a really response to, because we know who's in the network. We have a denominator term, which is helpful for analyzing these data. And so in this study, in these 2 countries, the people were an average of 27 years old. People in Eastern Europe are well educated, 15 years of education, most single, most working, most tested. 7% said at baseline that they were aware of being positive. And we did not get many people inject drugs. That was pretty low. We wanted to identify who were the leaders within these networks, who were the leadership structure, really, of the network. And we did it in 3 ways. The first was by looking at the interconnections among people in the network. That is, how often did participants, were they named by somebody else as a friend? And how often were these links reciprocal? That was kind of important. Then we also asked everybody a couple of sociometric questions, like how much do you trust each of the people you just gave us the first names of for advice? How trusted are they? How often do you interact with each? So we got an interaction measure. And then we looked back at our map to see, are there people that we need to have in here because they're connecting to people that would otherwise not be connected to a leader. So we identified about 30% of the people in these networks as leaders. And so, well, the seed, okay, there's somebody who's, well, there's somebody who's highly interconnected, and there's somebody who isn't particularly, but we have to get that guy because that's the only way to reach those other people at the outskirts. So that's how we ended up with that number of people within a network. At the time that people came in, they completed behavioral and biological assessments. The behavioral assessment was a partner-by-partner assessment of sexual practices for up to the 5 most recent male and female partners of in the past 3 months, type of partner, type of practices, whether or not sex was condomless. We administered some scales, pretty typical scales, measuring safer sex attitudes, knowledge, norms, intentions, self-efficacy. We asked, how often do you talk with people you know about HIV in the past 3 months, and also about AIDS? And then everybody stopped by a lab, and we collected biospecimens for testing for HIV, syphilis, gonorrhea, and chlamydia. We assessed through urine PCR, so we were going to miss some infections at other routes that way. Yeah?
To be in the study, did they have to agree to be tested?
They did not. They did not. Because some people said, I already know I'm positive, I don't want to go through this again. Other people were simply really worried about their status. They seemed to trust us, but not that much. And so we did not. So we're missing some data in our biological. Yeah. Yeah, this was an individual. So we took them. We had lab people that were going to be very good with our participants. We contracted. So everybody with an STD we immediately treated, so that should have gone to 0, and we verified treatment. People that were found through follow-up to be HIV positive would be an incident case, but we also made sure people were linked into CAIR. We had to develop high-quality care in both these cities, and we had to be able to give people something other than a referral to the local AIDS center where we felt would not be well treated, and we developed those ties as well. So our trial design, it looks like a pretty classic RCT design. 18 networks were randomized to 2 conditions. In the comparison condition, everybody got what I just said. At the time that they were tested for HIV and STDs, they got a high-quality individual risk reduction, STD, HIV risk reduction session. If infected, they were referred for care and taken to care. In the intervention condition, they got the same thing, plus the network intervention I'll tell you about. And everybody was followed at 3 and 12-month points later. So, comparison condition intervention was the traditional counseling and referral. The network intervention is what we were testing. So we identified the leaders of in these networks, the individuals most interconnected, most sociometrically important, and that would reach other people. They attended a 5-week intervention with 4 booster sessions together with other leaders of the same network. So sessions included between 5 and 11 people from that same network, 2 facilitators. Of the sessions, the 9 altogether, attendance was really high. Average 8 sessions attended. People came. And the aim of the intervention was to help the network leaders become able to talk after each session with friends, to provide risk reduction counseling, peer counseling, problem solving, and support. Sessions used group discussions, modeling, role play, feedback, and the leaders learned to talk with each person after. So the leaders got the list of everybody with whom they were interconnected. They got the names of the people within the network, And they were assigned after each session to have a conversation with each person to instill positive, safer sex attitudes, to suggest normative perceptions about benefits, provide advice about barriers to care and how to handle them, where to go for better quality care. Now, network leaders knew well these are their friends. These are the people that they talk to all the time. They're within their cluster of friends. And so we encouraged a lot of personally tailored advice and counseling. And at the beginning of every session, we talked about how this went since the last session. Now, some of you may be thinking, well, I think we heard something like this about 15 years ago, and you called it an opinion leader intervention. So this is, Jeff, have you changed? Over a decade. And you know, there are obviously similarities because both models, both the opinion leader model and the one I'm talking about now, really are driven by social support, social norms and perceptions and what friends think and talk about as behavior influences. But the POL model that we tested a long time ago, and we did this in Mississippi to a lot of other places, really identified key people from within a venue to kind of broadcast messages to other people. It was, I think, well suited at that stage in the epidemic where a lot of change could be produced by informational messages and some peer support. By contrast, the network intervention is a lot more targeted and a lot more intensive. So we're defining here, we're working on defined high-risk networks within a larger community. Also, this intervention, the network intervention, is not venue-based. You don't have to have a gay bar to do it. You can do it any place, anywhere where people are connected, including in virtual environments. So it's not a venue-based intervention, and it's well-suited, we think, for people that don't appear in a place but are in fact known to friends of theirs. The intervention itself is more intense, much more counseling-focused rather than broadcast messages. And the other thing, the reason that we like these network models where you know the number of people and the denominator term is you can start doing things to look at how messages diffuse within a network, and you can look at high exposure to the intervention, and you can look at network characteristics like density and a bunch of characteristics, or you can look at positions of people within a network in relation to change. So you can do a lot more with it. Okay, so what happened here? After the main intervention phase, we asked people how often, compared to a baseline, did you talk to friends about safer sex, and it went up in the intervention group. Also, it tended to go up more in the talking about AIDS specifically, and there was no change in the comparison group over the same time. So people were talking more about this stuff. These are just a few selected outcomes. We had a bunch of them. But just to give you an idea, the green line is the intervention kit. This is everybody in the network. And then this is everybody in the comparison networks. And this is the percent reporting condomless AI with a non-main partner in the past 3 months, and it declined. Also significantly declined for having unprotected anal intercourse with multiple partners in the past 3 months. There's a downward trend in the comparison condition, but much more sharp in the intervention. And percent who had UAI with multiple partners in the past that did it baseline, the percent that continued to at the past 3 months, and that declined also significantly. Our scales all changed in predictable ways. So attitudes, intentions, self-efficacy improved within the intervention group. So you might wonder, well, what about is it the 30% of people that came to the sessions? And when we took them out, we lost a lot of power, but at the same time, all the same, the values were basically what they were. So it wasn't just some people changing. Our biological outcome, STD and HIV testing at baseline and then at the final follow-up point, this is a hard one. This is why not to do a randomized trial with networks. It was just, we had 18 networks, so we have 9 and 9 things basically that we're comparing. Not exactly, but sort of like that. Hard to get power. We had 15% disease incidence over 12 months that we measured biologically. In the case of things like gonorrhea, more likely there are other cases that people got treated for, but we didn't want to mix self-report data with our biological outcome. 9% in the intervention network is the incidence of disease. About a third of that were new HIV infections over that 1 year period, and that's the pattern. Not significant, but it was about a 50% higher level in the comparison group over time. So the conclusions that you could draw from this is that, first, there haven't been very many HIV prevention trials undertaken in this region of the world. There's not a lot that's been done in Russia or any of these other countries. And there, in fact, have not been very many trials undertaken with MSM outside of in the West. In environments where same-sex behavior is very stigmatized or criminalized, it's possible to reach MSM through their social network connections, and that may be the only way to reach particularly hidden MSM in a community. Networks are vehicles for not only reaching people, but also for delivering interventions. Acceptance, attendance, intervention, exposure were all high. But is this an approach that would be feasible in the U.S. and perhaps feasible for increasing the uptake of treatment-based HIV prevention? And those are two questions, and I'd like to talk in the rest of my time about those. Everybody knows that African-American MSM continue to contract HIV at disproportionately high rates. The percentage of the U.S. population who are African-American MSM has got to be a fraction of a percent overall, but racial minority MSM constituted 25% of infections. This is not just true in New York. This is very true in Milwaukee, where, in fact, the disparities are even sharper. CDC has been to Milwaukee a bunch of times to see why this is the case. And a lot of people have gone looking for individual-level behavioral differences that might account for the disparity, but there have been very, very few. Condom use, risk behavior levels, things don't seem to be different. If anything, they may be a little bit better among African-American MSM. So people are now looking at network patterns, social networks, sexual mixing patterns, the higher prevalence of undiagnosed and untreated infection among black MSM, which may increase infectivity and transmission, lower ART use and viral suppression, simply the lack of HIV prevention interventions that have ever been really carefully designed for African-American MSM, and difficulties really reaching people who are very hidden in the community, especially when they're not gay identified. So we're doing a trial now. I don't have outcomes for this. In fact, I don't have outcomes for anything. You've seen the last outcome slide, you will. But we had a study underway for about 3.5 years in Milwaukee that we call C3, Connections Creating Change. And this is attempting to use the same sort of a network approach with racial minority MSM in two cities, Milwaukee and Cleveland. And so we're undertaking the trial in both cities. Both we have sharp disproportionate HIV rates. The study's paradigm is very much, remember I said Russia and Milwaukee, is very much like the Russia study I just told you about, but with a larger number of networks. We kind of learn our lesson there. The networks then begin with the seed and reaches 3 rings beyond. And there are 20 networks, so we're hoping, which is around 600 participants that are in the study. This is one. So we begin, that's our seed. So this is a sort of a more complicated looking network. So the seed reaches the people in the first ring, right? And then the people in the first ring reach the second and the third. And if we went out 2 more people, we would have Kevin Bacon in here. I'm sure we would. But it's kind of interesting when you start with one guy, the right guy, and you talk and you find their friends and their friends' friends, you end up reaching a very, very long way away from that first person. So in our C3 study with 600 men, there are again about 27, but 55% have high school or less education. Most have incomes of under $20,000. Nearly half are unemployed. A lot of them identify as gay or bisexual. Alcohol and marijuana use are very common. Other drug use, not particularly, 10% cocaine, about 20% illicit prescription drugs. Virtually everybody's been tested at some point.
Crystals?
No, no, we found not in Milwaukee and Cleveland. About 2/3 tested in the last year, and around 25% of the cohort said they were positive at their last test. So the trial looks like the others. We identified these these nodes within the network. We train, we enlist them to counsel their friends about. Now the intervention content's quite a lot different. It was tailored for the needs of African-American MSM. We preceded this with in-depth interviews and focus groups and things. Yes, Susan?
In each of those 9 sessions, if I'm a network leader, do I go back and speak anew to my folks?
What we would say, the way we wrote it, was that each session is going to have a different kind of a construct or a different sort of a theme. So you don't go back and tell them the same thing every time. You'd be shunned. And that messages build on each other, and that they become more intensive, and they become more, and that they're always personally tailored. What actually unfolds is probably not that. I think that probably the conversations end up not being, oh, this week we're going to talk about attitudes. It's not. They don't do that kind of thing. Yeah.
Participants asked to only name other African Americans in their network?
Yeah. No. We did not say that. But in fact, that's what it ended up being. So these networks were probably 85% African American MSM, but we didn't limit it. We did say MSM. But in fact, the close social networks that we were getting were primarily racially whatever. Same. Okay, so we're close to getting our final follow-up data. We haven't yet, but there were a couple things that we noticed in this baseline sample that piqued our interest. The first was the really large number of HIV-positive MSM in the sample, and then our observation that HIV-positive MSM have connections with other PLH MSM in their social lives. So those of us that have worked in this field for a long time, I think we've always known that positive people are clustered in their social network often with other positive people. This is an observation I think most of us have made for a long time. So in the C3 study and in several pilot studies, we've recruited and interviewed HIV positive, in this case racial minority MSM, and said, how many of your own personal close friends do you know are also positive? And the answer that we get always when we ask that question is 5. Sometimes 4, but 5. Across studies with white MSM, with African American MSM in the US, and then going to Russia, people who inject drugs and MSM in Russia, they always seem to say 4 or 5 close friends they know are also positive. So, then, if we begin with somebody who's positive, who's out of care, says, I haven't been to a doctor in a year or something like that, and we ask them the same question about their friends, we find that their friends are also out of care or also highly non-adherent. Okay, so this is this sounds like something somebody's doing or finding. Yeah. So birds of a feather flock together, right? This is what this fancy theory is about. So there are social networks in the community of positive people. And we think of networks as being of MSM or of drug users, other kind, but in fact there are networks of positive people in that some of these networks are composed of people with HIV who are not well engaged in care right now. So, as you know, as we all know, HIV prevention research is increasingly driven by the treatment cascade and junctures on. Some of those junctures are being rather highly investigated. Increasing regular testing uptake is certainly one. Linkage to care is certainly another. All right, a lot of stuff going on. A lot of stuff always going on ART adherence. Right? But there are other junctures on the cascade that have been much less studied. And so when I think about cascade depictions that I've seen more of than I care to shake a stick at, but the thing that you always see is linkage rates of newly diagnosed people. Yeah, they look good. They look good most places. But when you look further on the cascade, and when you look at retained in care over time, that's where the fallout happens. The fallout doesn't happen at the linkage point, it happens in the retention point. And then, if you look at U.S. data, or I don't know, if it's probably better in New York, but if you look at U.S. data, it does look to me like about half of people with HIV infection in the community have not been to a doctor in the last 6 months or longer. Now you could say, well, some of them may go in and out of care intermittently, so they're not or some of them may have moved. All right, so maybe not 50%, maybe it's 40%. But we're still talking about something approaching 500,000 people who are positive in the U.S. They're not going to benefit from linkage programs because they're not newly diagnosed. They may have been diagnosed a decade ago or a long time ago. So they're not going to benefit from adherence programs because they're not in care. There's this big group of people, I don't like to call people pools, but there's a big pool of people, huge, in the U.S., out of care, not being reached by current efforts, and until you get them, how in the world can treatment as prevention work on a public health scale? It can't, because half the players, a third of the players, 40%, 50%, aren't there. And that seems to me a really critical point in the juncture that we have not done nearly enough to address. So, why are out-of-care PLH out of care? So we carried out a couple of studies in which we recruited PLH in the community who said that they hadn't been to a doctor in a long time. One we conducted in Milwaukee, primarily racial minority MSM. The other we conducted, back in Russia again, with primarily people who inject drugs in St. Petersburg, positive people, not recently in care. And we took a leaf from your book. You know, you've always been the qualitative center. We did in-depth interviews and when you don't know something, you want to interview people and ask them. It seems like instead of trying to predict empiric predictors of retention and care, why not interview people and ask from their perspective, why aren't you there? So in Russia, we found something very striking. It was very clear, and that was that people were not in care because they were treated badly. The care systems were inconvenient, were judgmental. Somebody talked about 6 layers of gloves and jumping back, and this is an HIV care center. Worried about their confidentiality, lots of infrastructure issues. And that was specific to Russia, and it was strong. But in both Milwaukee and in Russia, we learned other things. Substance use, of course, was frequently cited as a reason for dropping out of care, not attending care visits. A lot of people we talked to had never been to care. They'd been tested at some point. They knew they were positive and never went. And when we asked, a very common belief was medical treatment is not needed unless you're sick. This is the grandmother test. You know, if you ask your grandmother, not an HIV behavioral scientist, ask your grandmother, when do you need to go to the doctor? And your grandmother's going to tell you when you're sick. Right. So we're trying to get people to, we say, why aren't they in treatment when in fact a person's feeling well? We're labeling it treatment and they may not. So there's a disconnect, I believe, between what we're trying to encourage people to do and their logical conceptions. We also found a lot of misconceptions about ART regimens, that you will take 24 pills a day and you're going to have diarrhea for the rest of your life, and they're going to make you sick, and besides that, they're toxic and they don't work anyway. Those beliefs are still there. They're still there among this 50% of people that are not in care. We find stigma and absence of social supports for entering, remaining, and adhering to medical care to be very prominent, and also fear of rejection, fear of being known as positive. That's bad, but those are the kind of factors that are amenable to change through interventions, aren't they? community intervention. Yeah, Pat.
The substance use, was it cited that, oh, I was high and I couldn't get my act together, or was it cited as when I go to CAIR and they know I'm a substance user, they come
No, it
And
was.
the third thing is that
Yeah.
if I'm using, I shouldn't take HIV drugs.
Uh-huh.
or
Yeah.
that, yeah.
I've heard that. quite a
We've
lot.
heard that. Yeah, we've heard that too, and
And there's
probably
something to it.
and probably a little bit more the beginning. I missed appointments because I screwed up.
Right.
Probably that was more the thing, but also what you're saying, Judy. So there are a bunch of things. So back to Russia. We're the only people in the world that pilot interventions in Russia. I got us. We're the only people foolish enough to do. So we're conducting a trial, and it's going along very well. Our recruitment's almost done, and here we're engaging PLH into care. So something like 19% at best of PLH in Russia are virally suppressed. It's very, very poor, very poor. Very small number are in care. So the trial I'm going to describe has been underway for about a year and a half now. Outcomes are not yet known, but I'd like to tell you just a bit about it. Similar to our other network studies, we begin with a seed. But it's always somebody who's a PLH, either recruited in the community, or in this one we're using online methods because we find they're very, very good, well-suited even there for recruiting people. But the criterion is that you can't be in care. So we're starting always with a positive person who's not been in care or who is not treatment adherent. We define that as less than 80% of recent doses taken, but actually it's way, way lower than that. It's nowhere near. And in this study, we were getting a little worried about going out 3 rings from an index because we just were pretty convinced our networks would run into each other. So we limited it to 2 rings. And 3 questions we're of interest at first. Are PLH interconnected with other PLH in their social networks? We thought so, but we wanted to know so. Can these networks actually be reached? Will they trust us? Can they be recruited? And then are out-of-care PLH connected to other PLH who are also out of care? And I think I told you the answers already. But okay, so this is one of those networks, the seed, first ring, and the second ring. And this is a network in, this was in St. Petersburg, Russia. So everybody's HIV positive. So it's a positive people network. And it goes out 3 rings. And we recruited 23 of these so far in Russia. They range in size from 2 to 44 members. So we've got some, there are only 2 people, but most of them are big. Usually about 9 people. Most of them are people who inject or did inject drugs. 26% were out of medical care that had no visits at all in the last 6 months, usually much longer. Although 69% had been prescribed ART at some point, a third missed most of their doses in the past week. And thus the recruitment reached PLH in the community, about half of whom were either not in care or didn't adhere to care at levels anywhere sufficient to produce viral suppression. So yes, it can work. Feasibility conclusions addressed. So we're adapted the model that we used in our earlier research, but we're approaching the midpoint of this study. But the intervention's different. Now we're using the leader intervention to encourage out-of-care PLH to enter medical care systems. We use the messages to encourage retention in care and to provide social support for treatment adherence as well when people are on. Now, we had to do more than that, actually, because we've got care systems that aren't very good. So we had to do basically a structural intervention on top of this to develop care provider networks that would, in fact, treat people well. If we send people back to where they were treated badly, they're not going to stick. So that becomes a part of the intervention, too.
How did you do that, Jeff? That sounds fascinating.
We based our team at an infectious disease hospital that is very progressive, and we'll use Western standard ART regimens even when many providers don't. Some HIV care in Russia now looks kind of like a history of the treatment of HIV, from 15, 20 years ago.
Does the government pay for medication?
They do, kinda. They do, but they won't use branded drugs, nor will they actually use generic equivalents. They do like there's listings of things that the state gives every 3 months to providers, and it's no telling exactly what's on the list. That may be a case where the 24 pills a day isn't just an artifact of the past.
So they don't use combination pills like Truvada?
No, no, no. They're put together with separate doses. Yeah. So it's a hard thing. Okay, so the here are the network leaders of these PLH networks are given current information about the benefits of ART and also where to get Western level care, correct antiquated and accurate beliefs. Presenting ART, so again, the perception is ART proves that I have a terrible illness and I'm dying. That really still is a perception. Still is a perception. And redefining it as a pathway to a healthy life, creating positive attitudes towards treatment and its benefits, identifying, providing, linking people to sources of respectful quality care, problem solving all the practical things that block care, access, logistics, transportation, child care, substance use intervention, and then discussing practical adherence strategies with your own friends. Again, people that you know are also positive. So the network intervention, again, teaches people to do this, and then talks about how those are going week to week. In the study, our outcomes are going to be number of PLH in the intervention condition networks who had HIV medical care visits in the last 6 months, or maybe more particularly at least 2 in the last 12 months, proportion of scheduled visits that we're attending, among people who are on HART regimens, those with high levels of adherence, and we're drawing blood at each visit so that we're measuring detectable viral load in people in both of the conditions. And these are being examined in intervention networks relative to comparison networks where a single session, risk reduction, treatment counseling, and referral to the same providers is offered. So far, everything I've talked about somehow has network leaders doing something to influence somebody else. But that's not necessary either within these interventions. You know, a lot of research has shown that care engagement and adherence are better when you have social supports for care. People here have done a number of those studies and showing couple supports and things influencing care. So supports can come from families and partners, but they can also come from friends, including positive friends. Now, if you look at the literature on adherence, for example, it's really driven by individual level interventions. Adherence, whether it's counseling or whether it's texting or whether it's doing something, it's working with individuals pretty much in isolation. Support groups related to adherence and retention have been done, but usually in the context of bringing together people that are patients in the same clinic. I'm thinking of Jane Simone's stuff. You know, she's like one of the very best researchers in this area that I know. And she's published a couple things where in clinics they create support groups of people in the clinic and see if the support groups improve adherence in a longer term, and the answer seems to be generally no. She hasn't found that. She's found them to be no more effective than anything else. But these are support groups that are composed of people that don't know each other. You know, they're brought together because they're in the same clinic. They're not really naturally friends. And so it would seem like that would be a bit of a problem. So we're also interested in the effects of a care-related intervention delivered together to a cluster of friends who are friends in real life. So back to this Russia depiction. Oh, there's one right there, right? So these people are all clustered with one another. We didn't measure the connections out here because that was the last time. And there's another one, right? And there's one right there. Okay, so you can take these networks and break them apart into these. Some people would call them egocentric clusters within the network. And so what we're doing now is intervening with everybody within that smaller unit. Those 2 or 5 or 7 or 10 people who are real-life friends, and we're doing an intervention that looks like a care, retention, adherence intervention, but the difference is the people aren't made up support group. They're real friends. So the content of this intervention is similar to that in our other studies, but with a lot more emphasis on friends supporting practically each other's care, engagement, and adherence. The intervention sessions are designed around informational, tangible, and emotional support, including carpooling and getting one another to appointments. It sounds a little like the buddy programs in the early AIDS era, maybe. And intervening with PLH who are friends in real life, we hope to bring about stronger and more sustained care-related benefits than one would get by working just with individuals in isolation from each other in some way. So let me conclude. It's not just the person. It's not just the individual. Within both prevention and care arenas, both risk reduction and care-related arenas, most interventions have been directed towards individuals. A lot of literature shows that sustained risk behavior, care engagement, treatment adherence are strongly influenced by social support, social norm, and shared experiences and efforts. So as the public health field increasingly employs early diagnosis, early initiation of care, and PrEP as strategies for prevention, interventions to support these kinds of care uptake, retention, and adherence must also be undertaken at social and community levels, not just individual counseling, if they're to get real staying power, if they're really going to have effects that last. Only by doing so will the full public health benefits of treatment be realized. I still keep thinking about this half of PLH that haven't been to a doctor, and this is in the U.S., or 40% or whatever. And that's just such a neglected group, and nothing's going to work in terms of all the modeling studies for driving HIV to nothing until you get them engaged. We have to, and the way you do it is through people they know. So innovative models are needed for reaching PLH in the community, supporting their sustained treatment engagement. This is a key thing, we think, in the field. And that was it.